Very good afternoon from the Giro d'Italia, and welcome wherever you are around the world watching live coverage of the 99th edition of this great race, where we meet and we breach the midway point in the 3 weeks of battle which are continuing to unfold in fascinating fashion. Well, if the sprinters thought that they had a straightforward day today, having been really denied a straightforward opportunity ever since the race left the Netherlands all the way up to the northeast of Italy, well, they've probably got another thing coming. Even though the opening section of this race is extremely flat, there are a couple of stings in the tail, most notably, I guess, the category 4 Forcella Mostacin.
Oh my god!
On arrival to the scene and throughout the scene, the clinician should have a calm, confident, easy to understand manner. It enables the patient and clinician relationship to start. It allows the clinician to gain trust and get the patient's cooperation in any assessments and further treatment that may need to be done. The first part of the assessment is the primary survey. It allows the clinician to quickly determine immediate care that needs to be given to preserve life to the patient, identify any further resources that are needed to keep the scene safe, or for helicopter backup for a quicker response to a hospital, and also allows them to find if they need to pre-alert hospital of anything that needs to be sorted quickly and can't be sorted at the scene. It goes through firstly assessing for danger, looking for safety to you, your patient, other crew, bystanders. Are you also looking to see if you need any PPE to keep you and your crew safe? Next is response. You're looking for AVP responses, alertness, so alert, verbal response, physical responses, or unresponsive. Catastrophic hemorrhage is then looked for. If the bleed is not appropriately controlled on the patient, it could end up with the patient dying. This is why controlling bleeding is important if there's a big bleed. In this case, the bleed wasn't too big, but it was still good practice to keep the bleed controlled and dressed appropriately with the correct dressings. Next, for airways, trauma patients are more at risk of a airway obstruction in a C-spine. We also need to be wary that we need to look after the cervical spine injury considerations, so we'll use appropriate airway management like a jaw thrust. We'll remove any obstructions that could be blood clots, teeth, or any debris that the patient's chewed up when they've fallen off. Next, their breathing. You look for the depth, their rate, SpO2 levels, and administer O2 accordingly. Circulation. Patient with trauma may have internal hemorrhages that are unseen to the naked eye. It's for the clinician to be aware of. They check for the capillary refill times, pulse sites, and allows them to administer IV fluid if they need it to preserve the patient's life. They then look at disabilities and exposures to do a top to toe to outline any other injuries or abnormalities to the patient that hasn't already been seen, and then check their AVPU status again. And the paramedic will keep going over this until it's all stable and they're able to move on to secondary survey and have a more in-depth look, including a history of the event as well.
5177 receiving.
We've had reports of a young male falling off a bike with quite a severe head injury. There's already someone in attendance. Could you go back it up, please?
Yeah, roger that. What code?
Red.
Okay, do that soon. 999 mode, activate. Drivers, they always pull out.
I know.
Pull out.
Any potential head or brain injury can be broken down into two main points, primary and secondary. Primary injuries are caused by direct trauma at the initial time of the accident, with secondary being any subsequent injury or deficit caused as a result of the initial incident. In the pre-hospital setting, the paramedic would be looking to identify and address any of the following. Soft tissue injuries are classed as any cuts or laceration to the head. As the head is a hugely vascular area, head injuries tend to bleed more, which may lead to certain conditions such as hypovolemia. The treatment of cuts and lacerations, the paramedic would be looking to close any open wounds to limit infection, to apply direct pressure to stop any bleeding, and if the patient did experience a loss of blood pressure, to potentially administer some fluid therapy to bring that back up. Skull fractures are broken down into four main types: linear, basilar, might have said that wrong, depressed or open vault, and the main problem with these would be infection. Through the patient assessment, mainly the palpation, the paramedic would also be looking for certain signs such as boggy masses, any leaking of cerebral spinal fluid, and also any periorbital ecchymosis. Going on from here, the paramedic may also be able to identify any potential nerve damage, as there are 12 pairs of nerves that leave the brain. They're often associated with skull fractures, and as they each define a certain area, it may be possible to identify any potential deficit in such. Depending on how the patient presents, the paramedic may also be able to identify any potential swelling in the brain, but this would have to be relayed to hospital staff for any treatment there as well.
Oxygen is used during head trauma to reverse any cerebral hypoxia. If it goes untreated, it will cause secondary brain injury. This potentially leads to a lower GCS and therefore airway management issues as the patient becomes more acidotic, due to the build-up of CO2 in the bloodstream and body tissues. Ambulance clinician should introduce early O2 therapy after their initial assessment. If they spot any red flags such as Ambulance clinicians should introduce early O2 therapy after their initial assessment if they spot any red flags such as combativeness, reduced GCS, lowered SATs, or reduction in respiration rate. Clinicians should work to the GR Calc oxygen therapy guidelines at 15 litres per minute and using a non-rebreathe mask for adults with critical illness. Any hemorrhaging with a head injury will result in a fall in mean arterial pressure and therefore cerebral perfusion pressure. The clinician should aim to keep the O2 saturation levels between 94 and 98% and monitor patients with vital signs.
After checking the C-spine, we noticed there was an abnormality. All patients with possibility of a C-spine injury should be manually immobilised, commenced at the earliest possible time, whilst initial assessment is being undertaken. If a mobilisation is indicated, the whole spine must be mobilised. We used a scoop stretcher and head blocks to ensure the spine was kept straight. We made sure the straps were tight as to ensure the patient didn't fall during the lift and egress to the ambulance. The cautions when immobilising is the threat of aspiration due to vomiting, so we had to be prepared with a suction device and stuff. As we considered were airway difficulties due to the collar, risk of aspiration, like I said, with the chance of vomiting, restricted ventilation due to the straps, and the skin lacerations due to the straps as well. Okay, ready, steady, go. Yeah.
At this stage, a secondary survey will be undertaken. This should generally follow a medical model. This starts off with a presenting complaints. What happened to cause the injury? If so, is there any pain? Where is the pain? Have you moved from the scene? If so, how? Do you remember the events fully, and was there any loss of consciousness? This could follow a framework such as sample, signs and symptoms, allergies, medications, past medical history, last meal, and events leading up to the incident. Following the presenting complaint section, the clinician would then begin to question the history of presenting complaint. What was the mechanism of injury? Was it from a road traffic collision? Were they wearing a seatbelt if it was to be? Was the fall from a height? Was there a penetrating injury involved? And was there any burns involved? This questioning could also undertake a framework such as OPQRSTA. Onset, provokes, quality, radiation, severity, time, and association of all symptoms. Following this, a past medical history will be asked upon the patient. Have they had any recent operations? Do they suffer with any clotting disorders that may alter any treatment pathways? Do they have any chronic medical conditions that may change observations? Following this, a closely linked section is the drugs and medication histories. Questions such as, do they take any anticoagulant medications, beta blockers, or do they undertake recreational drugs or alcohol? After the clinician has cleared the airway, breathing and circulation from a primary survey, they will then go on to assess the most relevant system. After this, they will do a top-to-toe assessment of the body.
An ATMIS handover is used to pre-alert the receiving emergency department of an incoming traumatic patient. It can be given over the phone prior to the arrival of the ambulance or in the emergency room once handing over to hospital staff. It is important because it allows the hospital staff to get a full, concise picture of the incident, the patient's condition, and the interventions done by the paramedics. It also allows them to determine whether the interventions by the paramedics were successful or unsuccessful. ATMIS stands for age, the patient's age and their gender. Time, the ETA arrival of the patient to the emergency department and the time of the incident. Mechanism of injury, what exactly happened to the patient, and other factors, i.e. were they trapped in a vehicle, did the vehicle roll, or others involved in the incident. Injuries, what injuries can be seen and what injuries are suspected. Signs, baseline vitals, also they note if the patient has improved or deteriorated since the arrival of the paramedics on scene. And treatments are interventions given by the crews. So for the incident at hand, the ATMIS handover would be We have a 34-year-old male patient who roughly 20 minutes ago at 2:30 p.m. came off his bike. He was travelling roughly 20 miles per hour, came off his bike, landed on his head first, and was wearing a helmet that is now cracked. We are querying C-spine injuries. He has a reduced GCS and a 3-inch laceration to the top of his head. The patient is transient responsive, tachycardiac with a reduced GCS. All other vital signs were in normal parameters, and there has been no change since our arrival on scene. Our treatments have: we have bandaged the wound on his head, we've gotten baseline vitals, we have given O2 therapy, and we have immobilised the patient.
That's a wrap.